Hi again, it's Dr. Jamnadas from Cardiovascular Interventions in Orlando, Florida. And I'm a cardiologist that is seeing patients with chest pain every day, here and in the hospital. And I'm going to explain to you today what is a heart attack. You should understand what causes a heart attack and why it can happen so unpredictably, and why it's important to do certain tests to find out if you have the conditions ready for a heart attack. So let's just start right away with an artery. I'm going to draw you an artery. So here's an artery, and the artery basically has 3 layers in the walls, as I've drawn in here. And over time, these patients can develop a blockage. So a narrowing starts occurring within the artery, and I'm showing it here in green. This is plaque buildup. But unlike what you think, most of this plaque is actually not building up on the inside of the artery, it's actually building up on the outside of the artery. So it actually is more like this. And that makes the whole artery swell. So unlike a pipe, when you get blockages in the arteries of the heart, only a minority of the blockage is actually on the inside, and much more of it is on the outside of the artery itself. So how do we know that this is the case? We know this from autopsy studies, and we also know this from CT scans. Why is this important? This is important because if this narrowing here is less than 70%, it's not going to restrict the flow of blood. So if you look at the flow of blood in this vessel, it's not impeded. You can see the blood is going right past it. You need a 70% narrowing on the inside of the blood vessel before the flow gets restricted. Now this vessel, that may impede some of the blood going through there. And when that happens, then this muscle is going to cry out. You're either going to get chest pain, or you're going to get EKG changes, or you may get a positive stress test because you're seeing the effects of this blockage. But what is interesting is that this blockage has to be more than 70%. I'm going to draw it in again here at 70%. What that means is that you can have a 50%, 60% blockage, and you can pass your stress test. And you can have a normal EKG. And you can have absolutely no pain whatsoever. That is why, if you pass a stress test, it doesn't mean you don't have any blockage. It simply means that you don't have a blockage that's impeding flow. And to impede flow, you need a more than 70% blockage. So how can we detect these states where it's less than 70%? Well, what we do here at CVI is we do a calcium scoring study where you can see that there's extensive amounts of calcium, because wherever you have plaque, wherever you see plaque like this, you're going to see calcium as well. And most of this calcium's on the outside of the arteries, and some of it may be impinging the artery. So typically, I do a calcium study, and the score may come back very high that this patient has a lot of calcium in the walls of the arteries. But the stress test is good. What that tells me is this patient has a lot of disease, but none of it is more than 70%. So then the question is, well, if it's not more than 70%, and let's say that the patient only has minor blockage, and I'm going to draw away the 70%, make it into a minimum blockage. What's wrong with that? What if it's only 20% or 30%? Let's draw in 30%. What's wrong with that? It's not causing any obstruction. No, it is a problem, because that plaque one day can crack. So this is a plaque, 30%. All of a sudden, one day, it cracks. That means it's like old wallpaper that bubbles. And when it cracks, a blood clot starts forming here. Now you've changed the flow dynamics of that artery in a matter of seconds. the blood is going to meet this blood clot and you have a problem. If this blood clot completely seals up the artery, there will be no flow going down that artery whatsoever. This patient is going to be having a major heart attack. A heart attack is caused by complete blockage in that artery. Went from having no pain today, could do a normal stress test, could do normal exercise, and all of a sudden, now the patient is having a heart attack. Severe chest pain, severe EKG changes, blood pressure may drop. This is a life-threatening situation. Now, sometimes the patients get a different scenario. Here's an artery, and just like before, there's lots of plaque in the artery, both on the outside and on the inside, but only minimum blockage. Just like before. Now it ruptures, blood clot forms, but this blood clot only causes a 50% narrowing, not 100%. So this blood flow is going to be restricted too, but not at this point. It's only 50%. So this patient, this blockage will cover itself over time. And now this patient is left with a 50% blockage. Patient may still be asymptomatic. So plaques grow because they can rupture and get covered over. Ruptured and get covered over. A few months later, another plaque may rupture here. And now you have another clot here. Now it may go to 70 or 80%. Now the patient develops angina or a positive stress test. Now sometimes these things can rupture, the plaques can rupture, make a little blood clot here, and the blood clot almost completely blocks the artery. Now this patient will present with what is known as unstable angina. New onset of chest pain. He hasn't had a heart attack yet, but he's getting new onset of chest pain. That is why if you have a new onset of chest pain, you got to come in and be evaluated right away, because all of a sudden you can visualize a blockage has happened. There wasn't a blockage, now there's a blockage. So this patient needs full evaluation immediately. We do a stress test, EKG, calcium scoring study, CT angiogram, but we have to determine that yes, there's a blockage. Why is he having chest pain? Why is he having EKG change? He hasn't had a heart attack yet. Now, a mini heart attack is when this blood clot here, tiny pieces can break off and go into the muscle and cause a mini heart attack, or sometimes it's still causing severe chest pain and some positive blood tests only because it's so tight. It's so tight, but there's still blood getting through it. So this is called a non-STEMI, where you get positive enzymes. Blood tests are positive. The troponin is positive. But the patient has not got ST elevation, meaning there's no regular heart attack. Here, the EKG will show ST elevation. Here, the patient will have ST depression. So it's a different type of EKG. So we can actually look at the EKG, examine the patient, take the history and look at the cardiac enzymes right here and tell, are we in the first scenario? Are we in a heart attack scenario? Or are we in this scenario here? Simple. History, physical examination, EKG, enzymes. And we can get to this point. And then we can do a stress test if you're at this point to confirm that yes, there's lack of circulation going on. And like I reminded you, you need a 70% blockage or more to show up on the stress test. Well, this will obviously show up on the stress test because it is more than 70% blocked. So I think that the take-home message today is that if a patient develops new onset of chest pain, you have to determine whether a plaque has ruptured, putting this patient's narrowing to more than 70 now. And the way we'll find out we'll do a blood test and we'll do an EKG and a stress test. Or if this patient's got new onset of chest pain and the EKG clearly shows a heart attack, then the patient is going to need some treatment in the hospital. For this, it's going to be obviously a stent. For this, it may be a stent also, but we have to wait and see what happens with the test results. Blockages don't just grow and close off the artery. Blockages rupture, get sealed over, rupture and get sealed over. So then the pertinent question is, what makes these blockages rupture like that? And that's what we do here at CVI. We look for your risk factors. Diabetes is obvious, but no, it's not just diabetes. It's hyperinsulinemia that predisposes the plaques to rupture. High blood pressure, low HDL, high triglycerides, a diet rich in sugar, obesity, patients who have inflammatory diseases, inflammatory bowel disease, inflammatory skin diseases, connective tissue disease. These patients have a propensity to rupture the plaques because they have inflammation in the body. The inflammatory markers are high. So in a prevention program, we can see that they have calcium, identify what other inflammatory markers they have, chase those to stabilize your plaque. So even if you have calcium, doesn't necessarily mean that it's going to rupture. We can do prevention. And we need to identify those prevention markers, chase them so that the plaques don't progress. I tell my patients all the time that you can live with your plaques, just don't die because of the plaques. Plaques can be there. You'll be 95 years old, you'll still have extensive plaquing. But so long as it's not causing a blockage more than 70, and so long as it's stable and doesn't crack, you're going to be fine. So this is a little brief going over what atherosclerosis is, what heart attacks are, what unstable angina is. And I hope you found this helpful. I'm going to make some more videos with you in more detail. If you like this, give us a thumbs up and sign up for our channel. Thank you. Hi everybody, it's Dr. Jamnadas from Cardiovascular Interventions in Orlando, and this video is going to be on how to treat a heart attack, and it's a continuation from my previous one where I explained what a heart attack actually is. So at the end of this video, you'll pretty much know how we manage an acute heart attack. So just to recapitulate, we know that the more plaque in the walls of your arteries, more calcium buildup in the walls of your arteries, the greater the risk that one of these plaques somewhere along here is going to crack. And when that plaque cracks, all of a sudden it makes a crack in the wall, just like old wallpaper, and a blood clot starts forming in here. And if that blood clot completely seals off the artery, like I've shown you here, now you have a heart attack. Heart attack is defined as complete lack of blood flow. There's nothing coming through here. So this muscle here is going to die. And typically the patient may or may not get chest pressure, shock, EKG changes showing ST elevation, and of course, the blood tests are positive. Your troponin is going to be positive. That's a blood test. So this patient, you can see this patient and know that the artery is completely blocked. ST elevation. This patient has basically got less than 90 minutes to make sure that this artery is opened up again. Otherwise, there's going to be irreversible damage done to this heart muscle. This heart muscle will all be dead, and it's going to happen if this artery is not opened up in a timely fashion. So when a patient complains of chest pain that does not go away, that could be a sign of a heart attack. It's usually in the middle of the chest. It's a pressure. It's not pain. It's a pressure. It's a heavy feeling. The patient breaks out in a sweat. Sometimes they get shortness of breath with it. They feel like the end of the world with a heaviness on their chest. And sometimes they can pass out. Blood pressure can be low. But I can tell you, after 30 years of seeing patients with heart attacks, they usually describe a heaviness in their chest, throat, jaws that doesn't go away. It's not a pain. They often sweat. They break out in a sweat, an unexplained sweat. And they often say that they can't take a deep breath in. They just feel lack of air. And this continues for more than a few minutes. That could be a heart attack. Especially if you know that you have coronary calcium in the walls of your arteries already. That is why it's important to do the coronary calcium score. Because you may have passed your stress test, but like I said in my previous videos, you can pass your stress test. You can have a normal looking EKG, you can have a normal echocardiogram, but you can have extensive calcium in the walls of the arteries. And if you have extensive calcium and now all of a sudden you're complaining of shortness of breath, which is unexplained, or chest pressure, that's a heart attack. So this patient will need to be emergently transferred to the emergency room and from there straight into the cath lab. So when they arrive in the ER or when the paramedics see them, they see that the EKG pattern is very typical pattern of a patient that's having what we call a STEMI, ST elevation myocardial infarction. And the way we treat this is that we go in with a wire into the artery, we go through the clot, put the wire down there, and then we slide a stent into the vessel over the wire, and the stent is like a spring that squashes the clot and pushes it up into the wall and restores the lumen of the vessel. So that's what a stent angioplasty is, opening up the blockage quickly using a stent. Now, before we get to that point, we give the patient aspirin. We sometimes give them heparin. Why? Because you want to start dissolving this clot ahead of time. Because by the time you get into the cath lab, you may actually dissolve a substantial amount of this clot. And then sometimes we give them a clot buster called TPA, especially if you can't get into the cath lab in time. So sometimes the cath lab is too far away. And if you're in a peripheral hospital, they'll give you TPA, which will dissolve this blood clot. So we give the patient a small dose of a beta blocker, aspirin. Sometimes we give them Plavix ahead of time, or TPA. And then the stent angioplasty is the final procedure that we'll do to eradicate this blood clot. Now, oftentimes patients don't have a full-blown STEMI, and as I've explained before, they just have unstable angina. So now their EKG shows ST depression, T-wave inversions. They have a specific pattern on that EKG. They're still having chest pain. Those patients will have a clot in them, and when we do the angiogram, you'll find that the artery is really narrow. But now that you all know from my previous lectures and this lecture, not all of this narrowing is caused by plaque. The plaque may only be this much, and the rest may be all blood clot because it ruptured and increased the blockage. So in an unstable setting, what we're stenting is not just plaque, it's plaque plus blood clot. Because the day before, the patient had only a 50% blockage or a 60% blockage. But today, the patient presents with severe lack of circulation. You know it's a plaque that has ruptured, a blood clot has formed on it. That is why the best thing to do is to actually take an aspirin if you think you're having a heart attack. But becoming educated first about what causes atherosclerosis is very important. So yes, we can help with the myocardial infarction and try to limit the amount of damage, but prevention is the way to go. Prevention means preventing what? You need to know what you're preventing. If you think you're bulletproof because you passed your stress test and echocardiogram, I'm sorry, that patient is misinformed because he's missing out on an opportunity for prevention. You get a coronary calcium score also. You're also going to know that I have plaque. Therefore, I am in trouble. I need to repeat my scan again in a year or two to make sure my calcium score is not going any higher. And I need to identify every risk factor possible that's going to tell me whether my plaque is going to be stable or it's going to rupture. I need blood tests for inflammatory markers. I need to have a good stress test, of course, to make sure I'm not having arrhythmias because of my blockages. I need to review my entire dietary plan. I need to know exactly what to eat, what not to eat. I need to identify all the factors in my history, such as high blood pressure, hyperinsulinemia, obesity, obstructive sleep apnea. All these issues come together and cause plaques to become unstable and rupture. Extreme emotional stress, extreme physical stress, severe bereavement can also make plaques unstable. So we know the factors, but you need to identify which of all the patients are at highest risks. Those with the highest calcium score are at the highest risk. I repeat the calcium score every year or 2 years, because if I see that the score is going higher and higher and higher, I know that you have risk factors which haven't yet been identified or treated that is giving you a higher and higher score. Today's cardiology is quite different from the cardiology of 10 years ago. So a stress test is not enough, an echocardiogram is not enough. A basic examination is not enough. Much more is needed. So I hope you found this helpful about what actually causes a heart attack and how to acutely treat a myocardial infarction, why it's important. Because you have 90 minutes to get that artery opened up. And the artery narrowing is blood clot and plaque combined. Plaque rupture is the biggest culprit. So I hope you found this helpful. If you did, give me a thumbs up, and I'll make some more videos for you all if you sign up on my channel. Thank you. Well, hello again. This is Dr. Jamnadas, and I'm with Cardiovascular Interventions. I'm the director here. And today I'm going to talk to you about right heart catheterizations and how we do them. Catheterization, where I'm going to look at the pressures in the lungs, because when a patient is complaining of shortness of breath, by doing the right heart catheterization, I can make a determination as to whether it's coming from your lungs or whether the shortness of breath is coming from the heart. So measuring the pressures inside the lungs is very important, and usually these patients are wide awake, or they may be sedated if there's a lot of anxiety, just like this patient here is very happy. And we're going to hook that up to pressure now and see what his pressures are. So measuring the pressures in the heart and the lungs is completely painless. Patients don't feel anything whatsoever. Now we're going to see the pressure readings up on the screen. This is a Swan-Ganz catheter that is inserted through the arm, not the leg, in order to measure the pressures inside the lungs, and we do this for patients with pulmonary hypertension also. So an important part of the workup of patients who have shortness of breath, for example, is to measure the pulmonary artery pressures to make sure they don't have pulmonary hypertension. And we can monitor those pressures, and it's all done right here through the arm. We don't even have to go into the leg, and it literally takes 10 minutes to know the pressures. So we've just finished this cardiac catheterization right here in the office. We've determined the state of the arteries and the pressures in the lungs and the heart pump, and this gives us a clear-cut idea of where we need to go with the patients. In the outpatient setting, the patient will be home an hour after this procedure, especially since we do it from the arm. When we do it from the leg, there's usually a little longer period of time that they have to stay on bed rest. So this is a very convenient way for a patient to do a procedure all through the arm only. And as soon as they're finished from here, they're taken into the recovery room, where they will spend the next 1 hour and then go home. They'll drink lots of fluids when they get home, and there are no other restrictions basically, unlike the femoral approach where you go in from the groin. But basically, having a cardiac cath lab in our office has changed the way we manage our patients, because we can do everything right here in the office and we can see exactly what's going on. No more guessing. We know exactly precisely what's going on. And accuracy is most important in cardiology. You need to know what you're dealing with, and guessing is not in the game here. So thank you for watching this video. Hello again, this is Dr. Jamnadas with Cardiovascular Interventions in Orlando, and part of my educational program, today's topic is EECP. And EECP is not really heard of much, but I've been doing it for 20 years in my office. So what is EECP? EECP stands for Enhanced External Cardiac Pulsation Therapy. And what it involves is we place blood pressure cuffs, large cuffs, around the thighs and the calves and around the pelvis. And then the patient's attached to an EKG machine, and based on the EKG, the blood pressure cuffs on the legs come on and squeeze the legs and release. Squeeze and release. And when they squeeze, the blood column in the aorta and the legs moves up and into the coronary arteries, creating a pulsatile flow in the coronary arteries. So you get increased blood flow in the coronary arteries. And when you do that, that is what enhances the blood flow inside the coronary muscles, and the patients feel less angina. So this therapy is conducted in the office, and the patients lie down on the machine for 1 hour at a time. And we have 35 sessions. So Monday through Friday, 5 sessions. So it's a 7-week program. And the idea is that by doing the counter pulsation every day for 1 hour, the patient will build up what we call collateral blood flow. So what is collateral blood flow? Collateral blood flow is that when there's a blockage in one of the arteries of the heart, these counter pulsations will stimulate the growth of little side vessels that will bypass, find ways around the blockage and supply the muscles further down with blood and oxygen. Thereby, the patients don't get chest pain. So it's predominantly used and approved by Medicare for patients who are still having angina, or patients who have blockages that you cannot put a stent in, or you cannot do bypass surgery, or the patients opt not to have those types of invasive procedures, and they want a natural way to grow new blood vessels in the coronary arteries. So it's not it's not as glorious as bypass surgery, but does it work? And the answer is yes, because these patients that come in here dedicate the time to do this. More than 2/3 of them notice a difference within 2 weeks. At the end of the course, 90% of the patients have said, not only to me, but also in the reports, the published reports, that their angina is much better. Functionality is also better. Shortness of breath gets better. So this therapy is performed in the office, EECP. It is approved by insurances and Medicare. We identify these patients in our office by first looking at the angiograms to make sure that their arteries are so bad that I can't put a stent in them and they're not candidates for bypass surgery. On the other hand, we found that once we started doing these EECP procedures, a lot of patients who had shortness of breath started saying that their shortness of breath is better. And subsequently, the studies have now shown that the diastolic function, which is the heart muscle relaxing actually gets better as well. And when that happens, the pressure in the heart gets lower, the wedge pressure gets lower, the patients have less shortness of breath. So actual myocardial systolic function, which is the contractility of the heart, may not improve drastically, but the diastolic indices, meaning the relaxation of the heart muscle, does appear to improve after doing ECP, and therefore shortness of breath gets better. In fact, there was one trial that showed that even congestive heart failure patients did benefit from doing this therapy. So currently, the insurances will not pay if that is the diagnosis, which is congestive heart failure. They'll only pay for this coverage if the patient has angina. So the cost is fairly expensive if you're going to pay cash out of the pocket. But in the overall scheme of things, it's not that expensive. It's approximately $4,500 for the entire course. Most of the ones we do here are covered by insurance, but I occasionally get patients who come here with no insurance, or they want to do this outside the insurance. But an intriguing number of patients recently have been coming here because we're doing coronary calcium scores on them, and they have extensive amount of calcium built up in the walls of the arteries. So we know that coronary calcium in the walls of these arteries is equivalent to atherosclerosis. But when blockages build up in the walls of these arteries, it can grow inside the lumen or on the outside of the artery. So we now know from autopsy studies as well that most of this atheroma or atherosclerosis grows on the outside of the artery, and only a minority actually constricts the artery. Now, if it constricts the inner lumen of the artery, the patient will either have a positive stress test or will start having angina. So a narrowing inside the artery caused by atherosclerosis, caused by calcium, is very easy to detect because you can see it on the stress test, and also the patients will be complaining of some chest pain, or may not complain of chest pain, but they'll have a positive stress test. But the vast majority of patients who have a high coronary calcium score are not having chest pain, and they're not having a positive stress test, but they have a lot of plaque. So what's the problem with that? Well, the studies have now clearly shown that the more coronary calcium you have on the walls of the arteries, the higher your risk that it's going to rupture. And if that plaque ruptures in the walls of the arteries, a blood clot forms there, and suddenly you go from good circulation inside the artery to a huge blood clot, and now you have no circulation. So that patient will now present with a heart attack. So a myocardial infarction, which is a heart attack, is not caused, as most people think, by gradual narrowing of the artery to the point where, oh, well, now it's closed off completely. Because most of those patients, you'll be able to pick them up either through a positive stress test or they're having symptoms. A majority of the heart attacks, over 75% of all heart attacks, occur at sites in the artery that are less than 70% blocked. So they're not restricting the flow, because flow in an artery is only restricted at 70%. So these people are walking around having a great time. They may even climb a mountain or go hiking and they have no chest pain. The next day, if they have coronary calcium, if they have atheroma, it suddenly cracks and a blood clot forms. So here, with the onset of these investigations we're doing with coronary calcium study, which is a CT scan, it takes only 3 minutes to do a CT scan. And we can see that the patient has built up all this calcium in the walls of the arteries. Then we do a stress test and we say, well, you know what? It's not causing any blockage. We need to put you on a prevention program. And our prevention program is very rigorous over here. But in addition, some patients have opted to do ECP. So the question is, why would you do ECP in that patient when they're not having any chest discomfort? So this is quite controversial, but it will not be covered by insurance. But think about this. If an artery shuts down because of a blood clot, and if you have good collaterals, then the day that happens, you will survive the heart attack because you've got lots of collateral, so you won't get the massive amount of damage. When you don't have collateral blood flow and you only have one major channel and that shuts down, you suffer from a massive amount of muscle damage because of the lack of circulation. when you have adequate collaterals, those collaterals save muscle. So even though you do get the heart attack, you don't end up with cardiogenic shock, or you don't end up with a very low ejection fraction. And we know this is true because in young patients, they haven't had time to build up collateral, so when they get a heart attack, it's a massive heart attack. Versus that same location, same artery shutting down in an older person, let's say in his 80s, he's actually going to paradoxically survive that heart attack because he's had time to build up collaterals. So over the past 30 years of practice, I've noticed that older patients do have better collaterals. Well, why don't we take younger patients who have coronary calcification, who have atherosclerosis, who are at risk of rupture, and create the collaterals of an 80-year-old so that when they do get a plaque rupture, they are less likely to suffer from a massive myocardial infarction. So they may still get the heart attack, but instead of the ejection fraction dropping to, let's say, 30% and causing catastrophic congestive heart failure, they may end up with a 45% ejection fraction. So are there any studies that have been done to prove this? And the answer is no, because you'd have to do a randomized control study to show that yes, if I did ECP when you're in your 50s and then you get a heart attack in your 70s, you are more likely to survive that. Well, you can see that the chronology is just not going to be a practical one. So my position on this is that patients who have a high coronary calcium score, and incidentally, everybody at risk should be doing their coronary calcium score. If they're at high risk, this is another modality that they should consider, the EECP. And you do the course, and you're going to do up lots of collaterals. So God forbid, if one of those plaques ruptures, you're actually going to have a greater chance of survival. So when I see these patients in the office now, we do offer them a wide variety of treatments for atherosclerosis. EECP is one of them. For angina patients, patients who also have inoperable coronary artery disease, severe disease not amenable to angioplasty, diffuse disease, where the arteries are exceedingly tiny, and patients who have high coronary calcium scores. So I hope this is interesting to you all, because I think that atherosclerosis has been misunderstood for so many years. The cause of heart attacks has been misunderstood for so many years. But now we understand plaque builds up, calcium builds up. But the bigger danger is when it cracks and causes a heart attack. That's the danger. And then if you don't have adequate collaterals, you're going to have a problem. So folks, I hope you enjoyed this. If you did, please give me a thumbs up and subscribe to our channel. And I'll bring you some more educational videos in the future. Take care. Hi there, it's Dr. Jamnadas from Cardiovascular Interventions in Orlando. And this is an echocardiogram machine. And what we're looking at is an image of the heart as it's contracting. And you can also see the valve function. And we can see the pericardium, the strength of the contractions, if there's any blood clots inside the heart, vegetations, abnormalities, previous heart attacks. A lot can be told by what's going on in the echocardiogram. So we do utilize echocardiograms a lot to evaluate your heart muscle function and your valves. But this machine can also do a lot of other things. So this machine will evaluate your carotid arteries to see if there's a narrowing in them. Same thing, it's just the ultrasound procedure and it's non-invasive. And we also use it to look for aneurysms in the aorta to make sure there's no aortic aneurysm. And we also use it for circulation in the legs. In the legs, we look at arterial and venous circulation. So we can see the arteries, make sure there's no blockages in them, measure the pressures. And we can also look for clots in the veins. Besides looking at clots in the deep veins, we can also evaluate leaking superficial veins. which cause edema or swelling of the legs and varicose veins. A lot of patients have severe swelling in the legs, but they don't have any visible varicosities, but they have leaking valves in those veins. We call that chronic venous insufficiency or venous disease, and this machine can evaluate that as well. So we have a comprehensive setup to evaluate all aspects of the circulation, but the ultrasound is a vital part. For this, it's non-invasive, so the patients don't need to be prepared in any way. You don't have to be fasting, and it's all non-invasive. Lie down on the table here, and some studies take a little bit longer than others, but on average you can get the study done in about half an hour. So this is what the ultrasound machine is, and we also use it acutely in patients that come in and walk into the office with severe pain in the leg, and we can make a diagnosis acutely of a DVT, acutely of pericardial effusion. So these are emergencies that we use this ultrasound for a lot. And I hope you found this helpful. And if you did, give me the thumbs up and we will send more videos your way. Thank you. Hi there, it's Dr. Jamnadas again from Cardiovascular Interventions here in Orlando. And I'm going to tell you today about this tiny little gadget in my hand. And this is a leadless pacemaker. It's actually a pacemaker. And I'm going to teach you a little bit about how we do this and why we do it and how valuable this really is. So it's a tiny little device. You can see it's not even 2 centimeters long. And before we do that, I have to tell you about how a regular pacemaker is inserted. So I'm going to draw you a little picture here. And here's the right ventricle. This is the left ventricle. And the right ventricle is a thin-walled structure. And what comes into this right ventricle is the venous circulation. So all the veins come back into this area here, and we have a tricuspid valve and the right ventricle. So when we want to put a pacemaker inside the heart, we put it inside the heart in the inner lining of the heart, and we usually can come from the right side or the left side of the chest in a vein. So we make a small entry site in a vein, and all veins lead to the heart. So then the wire is threaded under X-ray. We bring it down into the right atrium, across the tricuspid valve, and put it inside the right ventricle. Now, this pacemaker is attached, and it will supply the electricity when needed to come down, and it stimulates the inner lining of the right ventricle. It's a demand pacemaker. You will notice that when the electricity starts in the right ventricle, it then moves in every direction and causes a contraction of the heart. This is a single chamber pacemaker. So how is this new device inserted? It's totally different. For that one, I'm going to move a little bit this way and draw you another diagram of the heart. And here I'm looking at the heart sideways. So this here is the vein that comes from the top portion. So normally we would come in this way, go across the valve and insert the pacemaker wire. This is the inferior vena cava that comes from the bottom, and all the venous blood goes up, comes into the right atrium and then into the right ventricle. So this little device is brought in through a catheter from the groin, from the leg. So we take a hollow tube and we put this hollow tube into the right ventricle like this. So now we have a hollow tube that goes from the groin up into the heart. Once it's inside the heart, then I take the device, which is that little tiny device that I showed you, and I put it inside the tube, and I push it inside with a wire, push it, brings it all the way out here. And once it gets over here, it has tiny prongs on it. And I will hook it via those prongs against the wall. And once it's placed against that wall there, the hollow tube is taken out and this device stays behind. So this is a device that basically hangs on to the wall of the right ventricle, and it will supply the heart muscle with the electricity that it needs. So as the electricity comes around, the heart will beat again. So this tiny device has a battery in it, and that battery will actually last many years. On average, 7-8 years, even more, depending on how often it's being used. There's no wires attached to it. This little device will detect the own electricity of the heart, and when it's absent, it will then release an impulse, and that will make the heart beat. So it's also a demand pacemaker. Just like the one that I showed you here, which is a demand pacemaker, this is also a demand pacemaker. But there's no wire, and it is attached to the inner lining of the right ventricle. The left ventricle, of course, is on the other side here, and that's untouched. But the electricity spreads to both sides of the heart. This little device cannot be retrieved again once it's deployed. Once it's in there, it's always going to be there. So when it goes out of battery, then what do? Then we simply insert another one. So once this thing is out of battery, we'll put another one right in there. It looks like a little jelly bean, and it'll be inside the inner wall of the right ventricle. This is an amazing technology. Right now, it's only being used to pace the right ventricle, but we are in the process of seeing newer technological advances where it will eventually sense the electricity in the upper chambers and pace in the lower chambers. And some new devices are coming out where we will be able to pace the left ventricle as well as the right ventricle and the right atrium, but those are in the investigational stages. So pacemakers have come a real long way, and I will use this type of device on a patient who has occasional need for pacing, and in patients who don't otherwise want to have an endovascular procedure done. Maybe they've had endocarditis before, they've had infections, and the veins are not accessible. Then those patients also will benefit from this type of pacemaker. So this is not a defibrillator. We'll talk about that on another occasion. But I hope you found this helpful, that if you are told that you're going to get a leadless pacemaker, then this is what it's all about. Give me a thumbs up and look for our other videos. Thank you. Hello again, it's Dr. Jamnadas from Cardiovascular Interventions here in Orlando. And I'm very excited today to bring you a short video on a new tool that we have to manage congestive heart failure. Now, congestive heart failure is one of the biggest problems we have today because it results in numerous admissions to the hospital. And typically these are cardiac patients who fill up with water in their lungs and they can't breathe very well. They're very short of breath, or they are in pulmonary edema. And oftentimes there's very little clinical warning. Within a day, within a matter of hours, they can't breathe and they end up in the emergency room and sometimes even on a ventilator. So we have always wondered, can't we put a device in the patient where we can preempt this admission, where we can find out ahead of time whether this patient is going to go into congestive heart failure or not? We need some sort of a measuring device that's telling us that the pressures in the lungs are going up and this patient is going to go into pulmonary edema. Pulmonary edema means congestive heart failure, water buildup in the lungs, the patient can't breathe, the patient has swelling in the legs, weight gain, can't lie down, can't walk without severe shortness of breath, can't talk without shortness of breath. And this congestive heart failure occurs in patients who have good, strong heart muscle function and weak heart muscle function. It can occur in both groups. So what is this little tool I'm talking about? This tool is called a CardioMEMS pulmonary artery monitoring device. Big word. And this is a tiny, tiny clip. It is so small. It measures about 3 millimeters by about 8 millimeters at most. And it is suspended in the pulmonary artery. And that's the place in the lungs that water builds up from. So when the pulmonary artery pressures go up, the patient goes into pulmonary edema. So the question really is, how do we put this device into the lung? Well, first I'm going to tell you that this device is so tiny that it's delivered via a catheter. It does not have a battery in it. It is made of a very special material that is pressure sensitive. So when there's pressure applied to this device, it can give an electrical and magnetic field around it that then interferes with another field that you can create around it, and that change in the field can be detected and monitored and graduated. What that means is that if there's more pressure around this device in your lung, the greater is the pressure in your lungs, we can pick it up. And the advantage is that the pressures in the lungs start going up weeks before the patient gets congestive heart failure. Now I'm going to repeat that. What that means is that if this device is in a patient, you can pick up congestive heart failure happening a week from now. So while the patient is still asymptomatic, without any shortness of breath, this device is telling you the pressures are going up. So you can then monitor that and say, hey, come on in. We need to make an adjustment to your medication or your dialysis program, for example, or your blood pressure medication or your diuretic. Because if we don't do anything, 1 week from now, you're going to end up in the hospital with congestive heart failure. So this device does not make the patient feel better. It's not a therapeutic device. It's a detection device that will preempt an admission. It's a detection device that will prevent you from going to the hospital and basically tell your physician ahead of time that I'm going into congestive heart failure, and this device is going to prevent you from being hospitalized. So let's talk about how we get it in. As I said, it's done through a catheter. So the catheter is a hollow tube, and inside that hollow tube we put that little device and we push it all the way into the lung, and I'm going to show you how we do it. So the insertion process is a very simple one. It is done in the cardiac catheterization laboratory in the hospital. It's an outpatient procedure. You come in the morning, you're home by lunchtime, and we go through a vein, not an artery. So we can go in from the vein in the groin, which many people like, or you can go in from the jugular. So you go into a vein here in the neck or a vein in the groin. So I'm going to draw in red my catheter as I introduce it. I go up inside the vein with my catheter, and under X-ray guidance, I can bring it into the heart, through the right side of the heart, make a curve like this and go into the lung artery, the pulmonary artery, and bring it down into one of the branches on the left side. Once it's positioned there, I can deploy it. Deploy it means I can push it out of the catheter and then it stays behind. So it's a small little clip. Of course, I'm exaggerating the size. And then I pull back my catheter and I come out, and that little device stays inside. And it is suspended in the pulmonary artery. When we're doing this procedure, it's very similar to the right heart catheterization that many of you may already know, where we take a catheter and we measure the pressures in the right side of the heart. We will do the pressure readings also during this procedure, because then you can calibrate this device so that we know that this pressure correlates to this type of signal. Once the device is in position, it is not going anywhere. It is there permanently. nothing's going to happen to it. It doesn't have a battery, it doesn't rust, it will always be there, and it will be able to transfer information to the outside. So how do we do that? How do we get this data out? Well, that's very simple. Basically, we ask the patient to lie down on a special pillow. We'll detect the field around this device and generate a signal. That signal is then placed into our applications program, and we can tell from that signal strength what the pressure in the lung is. So let's say that I'm monitoring this patient. I will get a signal on a daily basis or as often as I choose to do it. And if this signal starts going up, and I know from my calibration that at a certain level here, let's say 18 centimeters of water, this patient is going to go into pulmonary edema. So it warns me that it's going up, and I can call this patient at time day number 4 and say, hey, listen, your numbers are going up and normally you are pretty good. And I can do an intervention either with a medication, lifestyle change, diet, or programming of devices such as pacemakers or ICDs, and I can make that number come back down to the baseline. And that's how it should be. When you see it breaking away, there is a problem. So this device has made our management of congestive heart failure a little easier. In fact, the studies that have already been done show that there's a reduction in hospitalization of almost 60%, probably more like 58% reduction in hospitalization rates. And that's a tremendous advance. And the patient doesn't feel anything. The minor inconvenience is the measurement the patient has to make by lying down on that special pillow for a few minutes and then transmit the information. So this little device is actually approved by most insurances also now. It's been in the making for a long time, and we've been eagerly looking forward to having it now available to all our patients. So if a patient has had congestive heart failure, and if the patient has recently been hospitalized within the last 6 months to the hospital, whether they have a weak heart or a stiff heart, if they have congestive heart failure, the situation is the same in both. The pulmonary artery pressures are high, we can detect it through this device and assist in the management. So we are very happy that we are able to do this now. And if you or you know somebody who has had congestive heart failure and you are interested in this particular device, please talk to your provider or come see us. So I hope you found this helpful. I'm Dr. Jamnadas again from Cardiovascular Interventions, and if you like this video, please click the like button and subscribe to our channel for more informative, cutting-edge cardiology. Thank you. Hi again. So it's me again, Dr. Jamnadas with Cardiovascular Interventions, and I hope you all are enjoying this series. Today I'm going to tell you about cardioversion. Cardioversion is when we give a patient an electric shock and bring the heart rate back to normal. And it's usually indicated for atrial fibrillation. So these patients usually have to go to the hospital, but I do this right here in my office. The patients come in here in the convenience of the office setting. We do the blood work, chest x-ray, then we bring them here and we attach the pads to the chest, and then we deliver an electric shock. Of course, before we give them the shock, we give them a little medication that basically puts them to sleep for about 30 seconds to a minute, sometimes 2 minutes. And then they wake up and then they go home. They have to go home with a ride. So electrical cardioversion is really important when a patient is having a runaway heart rhythm such as atrial fibrillation, very fast heart rate, or any other rhythm that will respond like atrial flutter. Usually they're on a blood thinner and they have to be on a blood thinner for a full 1 month before we do the procedure. So we check the blood tests as well, make sure everything is okay, bring them down here and deliver the shock. This particular patient happens to have a pacemaker as well, and then we always interrogate the pacemaker through this pacemaker interrogation device to make sure it has not been affected by the shock that we've just delivered. Of course, it also helps me to interrogate the device and look at his underlying rhythm. Sometimes I can even give the shock through a defibrillator. If they already have a defibrillator in them, I can deliver the shock through the defibrillator instead of externally. So it's a very safe procedure. We have a full staff over here available, and usually they wake up not even knowing that we did the procedure. So this is what a cardio version is. In case you ever have to have somebody have it done, you'll know and be educated about it. So I hope you're enjoying this series. If you like this video, give me a thumbs up and do follow our channel. Take care. Hi, so it's Dr. Jamnadas again from Cardiovascular Interventions here in Orlando. And I was asked this question that why do we do coronary calcium scoring studies? Now, coronary calcium score is simply a CT scan that looks at how much calcium has built up in the walls of the arteries of the heart. And the question is, why do we do that test? Well, we do it because it is truly a visualization of the disease process in the arteries. So instead of guessing that you probably have some hardening of the arteries, you can actually see the hardening of the arteries, because wherever you get calcification, you have atherosclerosis, which is hardening of the arteries. And that's the disease process that causes heart attacks. That's the disease process that causes that calcium or the plaques to rupture, and then a blood clot forms on it and causes a heart attack. So the more calcium you have in your coronary arteries, the greater the probability that something is going to happen. Either the patient is going to develop a heart attack, or weakness of the heart muscle as a result of the buildup of plaque and the lack of circulation, or arrhythmias. So quantitating the amount of calcium in the arteries is really important. And I'll give you a typical example. A patient came to me, he was around 52 years old, completely asymptomatic. And he went to his family doctor, of course, and had all the tests done, and his cholesterol was okay, nothing bad, didn't need any medications. His blood pressure was reasonable, and his examination, of course, was negative. EKG was normal. So he was not satisfied. So he comes here, we do a stress test, it's normal. We do an echocardiogram because he really wanted to know, and that shows that his heart muscle is good. But when we did the coronary calcium score, we saw that his calcium levels were very high in the arteries, and we could see that he had hardening of the arteries even though he passed his stress test. And the question is, how can that happen? And that happens because you need a blockage in the artery of at least 70%. That means a 70% narrowing inside your artery before the flow gets restricted. So you can pass your stress test even with a 60 or 70% blockage, as this patient did. But now that we knew that he's got coronary calcification, we said, well, we need to dig deeper as to why you're getting this coronary calcification. And then I found out that, yes, his cholesterols were not quite right, because when we did an advanced lipid panel, we found that he had a high-risk profile. And we also discovered that although he was not obese, he was definitely overweight. And we also discovered that he had a fatty liver, and his insulin levels were high. And I also discovered that he's always had a grumbling stomach, and we discovered that in fact he did much better when I switched him over to a grain-free diet. So we were able to implement things to change the natural history of the disease process. So instead of just the traditional risk factors that we look for more issues that cause inflammation in the body and coronary calcification. The other big advantage is that I can quantitate this year after year. So usually at 2 years, I repeat the coronary calcium score. And if that score is going up and up and up, it means that there are still ongoing risk factors that this patient has, which is dangerous because the calcium score predicts cardiovascular morbidity and mortality. So I'm looking for a flattening of that curve. So you can't eradicate the calcium completely. Maybe it can go down by 10%. But the important thing is at 2 years, it should not go up by more than 15%. So if there's no increase in the coronary calcium over 2 years, those patients usually have a fantastic prognosis. On the other hand, if the calcium score is increasing over time, that portrays a poor prognosis. So looking at coronary calcium is a very important part of today's cardiology workup, because the traditional risk factors where you're just a statistical probability of heart disease is just not good enough. A coronary calcium score gives you an exact definition of whether you have disease or not. So this is a picture of a CT angiogram where you can actually see the arteries as well. But this is what a calcium scoring study would look like. That white blip over here is the coronary calcium. It's a very low level radiation. The coronary calcium score does not involve contrast either. So I hope you found this very helpful for you, because coronary calcium studies are now an integral part of the workup in certain patients. So thank you very much for watching this video. If you like it, please click like and subscribe to our channel. Thank you. So in the cath lab, we also do peripheral interventions. This means putting stents or atherectomy devices inside the arteries in the legs or the iliac arteries to establish blood flow. Because when you have blockages, patients get pain in the legs, discomfort, even gangrene. And we actually bring them here and put these stents in them, and we can sometimes do what is known as a Roto-Rooter and open up the artery again and re-establish the blood flow. So this is where we do it. This is the cath lab for peripheral vascular interventions also. Well, hello again. This is Dr. Jamnadas, and I'm with Cardiovascular Interventions. I'm the director here. And today I'm going to talk to you about right heart catheterizations and how we do them. First of all, a right heart catheterization is simply taking the pressures in the lungs, and it's usually for patients who have a diagnosis of congestive heart failure or pulmonary hypertension. And I'm going to need to put a catheter inside the right side of the heart. And the way we can do that is traditionally we go from the groin. But of course that can cause some discomfort, and sometimes they're on blood thinners, or sometimes you can accidentally hit the artery. So the alternative way is to go via the neck. There again, the carotid artery is nearby and can cause bleeding, and of course the discomfort of having a needle in your neck. So what we've developed here is a very special process of doing the right heart cath from the arm, where we give little anesthesia on the arm and put in a little IV, just like you get your regular IV done. And I'm going to show you what that looks like. And then through that, we put the catheter into the heart, measure the pressures, and take it out. So here we have a patient that's already got an IV in the arm. And you'll see that this is basically just a regular IV, and it's going into it. It's a little 6 French sheath, as we call it. And there's fluids that are going through it. And then what I will do is I take a catheter which is this very fine 5 French catheter. So it's a very fine catheter, unlike the ones that we use from the groin or from the neck. And I can slide it into this IV, and it will travel under X-ray guidance all the way up to the heart. We can measure the pressures and the cardiac output, and then take the catheter out completely. And once the catheter is removed and discarded, all the patient's left with is a small little vein catheter, and this will be pulled out and hold pressure for 5 minutes, and the patient can be out walking. No sedation is needed for this. We use a little bit of lidocaine here, so there's no sedation. The patients come in and out, and we can do these anytime within 5-10 minutes notice. So that's it, folks. This is a simple right heart catheterization. It sounds like a big deal, but what used to be a big deal years ago today can be accomplished very easily in the outpatient setting in a matter of minutes and done extremely safely. So we've just finished this cardiac catheterization right here in the office. We've determined the state of the arteries and the pressures in the lungs and the heart pump, and this gives us a clear-cut idea of where we need to go with the patients. In the outpatient setting, the patient will be home an hour after this procedure, especially since we do it from the arm. When we do it from the leg, there's usually a little longer period of time that they have to stay on bed rest. So this is a very convenient way for a patient to do a procedure all through the arm only. And as soon as they're finished from here, they're taken into the recovery room, where they will spend the next 1 hour and then go home. They'll drink lots of fluids when they get home, and there are no other restrictions basically, unlike the femoral approach where you're going from the groin. But basically, having a cardiac cath lab in our office has changed the way we manage our patients, because we can do everything right here in the office, and we can see exactly what's going on. No more guessing. We know exactly precisely what's going on. And accuracy is most important in cardiology. You need to know what you're dealing with, and guessing is not in the game here. So thank you for watching this video. Hello again. This is Dr. Jamnadas from Cardiovascular Interventions, and welcome to our series. Today is a very important subject. The subject is the CRAFT test. This is a glucose and insulin test. It's a blood test, and we administer it right here in our office. This test involves drawing blood at baseline, half an hour, 1 hour, 2 hours, and 3 hours after drinking sugar water. What's the point? Well, we want to see how much your glucose goes up and how much your insulin level goes up. So you've heard of the glucose tolerance test, where you're monitoring your sugar response. How high does your sugar go? Are you a diabetic or not? And we found that many of my patients who I suspected may be a diabetic because they have hardening of the arteries, they've had heart attacks, they've had strokes. But when you look at the hemoglobin A1C, which is a sure sign of diabetes, or you look at the blood sugar levels, they're normal. So you say, well, they don't have diabetes, but then why do they have such severe heart disease? And over the past 5 to 10 years, we've realized that a large number of these patients may not be diabetic, but they're pre-diabetic, which is a condition that is extremely detrimental to the arteries. If you have pre-diabetes, you're going to get hardening of the arteries very prematurely, and it goes undiagnosed. So these patients don't even know that they have it, because they go to the doctor, they get the hemoglobin A1C, they get their sugar levels, and they are normal. So they think that for all practical purposes, they're not a diabetic, they're doing fine. So this test has been done to show that no, it's not your sugar level only, it's your insulin in the background and how high it is that determines your risk factor of developing hardening of the arteries, strokes, heart attacks, dementia, obesity, fatty liver, atherogenic dyslipidemia, high blood pressure. All these are conditions associated with high insulin levels. So I'm going to explain this test a little bit to you. So if you give somebody some sugar water and you'd expect their sugar levels to increase, but by 2 hours they start coming back down and back to baseline. And that's the response that normal patients get. Now, a diabetic, of course, will be way off the mark, but then he's already established as a diabetic patient. Here we have a pre-diabetic who will have a normal sugar response. But if you measure their insulin levels in a normal response, you'd expect to show that the insulin goes up and down. And that's a normal curve. But in pre-diabetic patients, the insulin goes way up and then down. And this is the abnormal response that I'm looking for. They make so much insulin, and that brings the sugar level down. But look how much insulin it took to bring that sugar level down. That is insulin resistance. The body is just not responding to this much insulin, so it has to produce massive amounts. They have resistance to insulin. Why would you have resistance to insulin? Multiple reasons why you have resistance to insulin, which we'll come to in just a second. So the way we do this test is we administer the sugar water, we measure the insulin levels at half hour, 1 hour, 2 hours, and 3 hours, and we document that, my goodness, the sugar levels are good, but the insulin levels are sky high. This patient has hyperinsulinemia. He failed the test. He's got a positive Kraft test. So the question is, why would you make so much insulin? And the reason is you have insulin resistance, and that's driven by 5 major factors. The first one is eating too frequently. Every time you eat, your insulin level goes up. And if within an hour and a half or 2 hours you're eating again and again, every 2 hours, you're constantly having high insulin levels in the body will become resistant to the effects of insulin. So the next time you eat, you have to produce a massive amount of insulin to get the same effect on your sugar. So a hormone cannot stay elevated all the time. There has to be cyclical increases in your hormone levels, not constant, because then you become resistant. The second reason is too much sugar in the diet. So what you do eat, if it produces a rise in your sugar, and that goes up with consuming sugar, and also starches and concentrated carbohydrates, then your blood sugar level will go up a little bit, but it'll take a lot of insulin to bring that down because you will develop insulin resistance. The third reason is fructose. Excess amounts of fructose will produce insulin resistance over time. And fructose is found today not only in drinks, but also in all processed foods. Too much fructose, and fructose will cause insulin resistance at the level of the liver. And then the fourth reason why they can get insulin resistance is because of liver disease from alcohol and other causes that can cause liver disease. And you'll get insulin resistance that way as well. And then the last one, which is the big one, is processed foods. If you eat something that's processed, then the same food in the unprocessed form will only produce a small insulin rise. But if it's processed, there'll be a huge increase in your insulin. This is also known as the incretin effect. And it's a little complicated, but bottom line is, if I give you the food in its whole food form, versus if I process it and powderize it, or make it into a flour, or process it and then give it to you in a form that is not recognizable anymore, it's man-made, it's made in a factory, it's going to produce a lot of insulin because of insulin resistance. The amount of insulin produced is totally different. Same calories, same food, but in a different form. And these are the 5 things we've been doing today. That's why we see an epidemic of prediabetes. And of course, this will eventually lead to diabetes itself, because when the insulin levels cannot go any higher, then the blood sugar will eventually start going up, and then you develop diabetes. So even this massive amount of insulin will not control sugar. So you will develop diabetes in the future if you have a positive test. So the point of identifying these patients early on is because we can make great strides with lifestyle changes and diet so that the insulin resistance can be restored. Can it go back to normal? Of course it can. You can shift this down. There are lifestyle changes, dietary changes that are needed to do this. We don't have medicines to do this. That's why the responsibility then falls on the patient to do it. And they need the right advice, the right diet, the right lifestyle. Then your insulin sensitivity will come back. And you can look around and I can pretty much tell who has insulin resistance. Insulin puts everything into storage. Where? In the liver. So they get a fatty liver, and then in the viscera, so they all have a large abdominal girth. That is insulin resistance. They're not obese all over, but it's all around the belly. And then the HDL is low. Their triglycerides are high. Their blood pressures are high. And these patients will have an almost normal hemoglobin A1C. It'll be usually less than 6. And the blood sugars, not bad, 100, 120. So if you're simply looking for diabetes, you're going to miss this huge group of patients who have insulin resistance. And this is the elephant in the room when it comes to atherosclerosis. And if we can bring this curve down and reduce your insulin response, your prognosis will change dramatically. When insulin levels come down, patients automatically lose weight because insulin is a storage molecule. So automatically they start losing the weight, and it's all fat loss. And these patients' blood pressures come down, their liver function gets better, they feel better, they sleep better, and the risk of developing cardiovascular disease goes down tremendously. Because those of my patients who have the best insulin levels don't get progression of disease anymore. And you can repeat this test. So let's say that you're on my program for 6 months, then we repeat the test and we show there's been a vast improvement in the insulin response. That's how you can tell that they're doing better. So the CRAFT test is something new. We do it right here in the office. It requires a 3-hour blood test, but it's well worth it. And I hope that this has been very educational for you. And if you like this video, please click like and please subscribe to my channel. And I'll see you for the next educational channel. Bye.